Here. So we'll kick off with the first session for the day, updates on cardiac screening, and I'd like to invite Professor Corrado from the University of Padua, who will be giving us a talk about putting screening into perspective, what we can achieve.
Thank you very much for this invitation. I'm once again here with you, so I'm very happy and very honored to talk about screening. So the aim of screening athletic population is to prevent sudden cardiac death by identification, early diagnosis in a pre-symptomatic stage, cardiovascular diseases at risk of sport-related sudden cardiac death. So the screening protocol should be adapted to the age of athletes to account for age-specific cardiovascular disease at risk of sudden cardiac death. In young athletes aged 35 years or less, the most important cause of sudden cardiac death include the large spectrum of cardiac diseases, congenital, genetic, or acquired, that account for 1 to 3 per 100,000 athletes per year. According to Italian experience, the risk to die suddenly in adolescent and young adults engaged in competitive sport activity result to be 3 times greater compared with a non-athletic counterpart. This is a strange result, but can be explained by the fact that sport is not in itself the cause of the increased mortality. Sport just acts as a trigger or a trigger fibrillation or arrhythmic cardiac arrest in those athletes affected by cardiovascular disease, predisposing to electrical instability during sport activity. This condition include these representative cases of athletes dying suddenly, autopsy findings. You can see in A, hypertrophic cardiomyopathy, in B, arrhythmogenic right ventricular cardiomyopathy, in C, premature coronary artery disease, and in D, anomalous origin of a coronary artery. These are the causes, but all these causes result in a common final pathway that is ventricular fibrillation, that is a mechanism of sudden cardiac death during sport activity. So inherited cardiomyopathy, such as hypertrophic and arrhythmogenic cardiomyopathy, are the most important causes of sudden cardiac death in the age range, in the young age range of athletes. And most importantly, these conditions are ECG detectable. So we demonstrated over a long-term follow-up in Italy, in northwestern Italy, that screening population of athletes according to the ECG protocol is able to reduce sudden cardiac death during sports. In 2005, the section of sport cardiology proposed a common European protocol for cardiovascular pre-participation screening of young competitive athletes with the aim to prevent sudden cardiac death. And this protocol of screening was essentially based on the electrocardiogram, and on the basis of the result of electrocardiogram, athletes should be evaluated with a further examination in order to confirm or exclude the cardiovascular disorder. So the long-running experience in Italy showed that screening can prevent sudden cardiac death in young athletes by identification of ECG detectable cardiomyopathies and channelopathies. This is the paper published in 2006 on JAMA, and you can see here that after the implementation in Italy of pre-participation screening in 1982, when the incidence of sudden cardiovascular death in young competitive athletes, the red line, was about 4 per 100,000 athletes per year, declined gradually over the time to become 0.4 per 100,000 athletes per year after 24 years of screening. That means a reduction of sudden cardiac death by screening of 90%, compared to no changes of the incidence of sudden cardiovascular death in non-athletes, that is the black line. And most importantly, this reduction in mortality was mostly due to fewer cases of sudden cardiac death to cardiomyopathies, hypertrophic and arrhythmogenic cardiomyopathy, and the reduction of sudden death due to fewer cases of sudden cardiac death from cardiomyopathy was paralleled by an increasing identification of athletes, living athletes in whom the diagnosis of cardiomyopathies was done during screening. So in other words, the athletes didn't die because were successfully identified by screening during the same time interval. So the third point I would like to address is that the enhanced screening protocol, including limited exercise testing, may be useful. So what does it mean, limited exercise testing? It's exercise testing that is not aimed to demonstrate myocardial ischemia, but just to demonstrate arrhythmias. So it's a protocol with a fixed watts workload of exercise, and is important because when is including electrocardiogram monitoring, is able to demonstrate premature ventricular beats during effort, and is able to increase the screening sensitivity for condition at risk of sudden death by 80%, as you can see here in this paper we published a few years ago. Mostly because allowed the identification of adrenergic-dependent premature ventricular beats that can predict the presence of non-ischemic left ventricular scar, as you can see here by cardiomagnetic resonance, that is an emerging cause of sudden cardiac death in young people. So another important achievement of screening this last year was the demonstration that serial ECG screening, that means ECG screening performed on a regular basis every year, like occurs in Italy, is able to further increase the sensitivity for diagnosing conditions such as acquired cardiovascular disease, for example, post-myocarditis scar or post-myocarditis disease, or genetic conditions with the late onset phenotype. Look at this result. We studied more than 22,000 consecutive young athletes with age range 18, and the protocol was enhanced by the limited exercise testing. And you can see here that we found 69, we had 69 diagnoses of condition at risk of sudden cardiac death, but most important, you can see here that diagnostic yield of each screening session was equal. In other words, was the same in the first evaluation and in the repeat evaluation. So in other terms, the repeat evaluation were as important as the first evaluation in order to identify this condition at risk of sudden cardiac death. In other words, you can better evaluate this concept by this slide showing that at-risk cardiovascular disease were identified over the entire age range of the population, but more frequently individuals aged more than 21 years, 90% of athletes with cardiovascular disease were older, 12 years, and most importantly, 64% of this condition were identified during repeat cardiovascular screening, not at the first evaluation. Most importantly, you can see here that at the end of this follow-up, there was just one case of cardiac arrest that was successfully resuscitated. So this was the first STEM document on recommendation for interpretation of 12-lead electrogram in athletes that allowed to distinguish group 1 common and training-related ECG changes that are benign versus group 2 uncommon and training-unrelated ECG changes that are potentially at risk. This first document was followed by further documents. The last published was the International Recommendation for Electrocardiographic Interpretation in Athletes, and these documents were aimed to increase the specificity, in other words, to reduce the number of false positives. That is very important to increase the cost effectiveness of the screening program, because lower the number of positive findings of false positives after first line examination, greater the cost effectiveness of the screening protocol. So the last point is sudden coronary death. We know that in older athletes, middle-aged and senior athletes, the most common cause of sudden cardiac death is atherosclerotic coronary artery disease that accounts for 1 to 15,000, 1 to 50,000 athletes per year. So like in this marathon, 47-year-old marathon runner who died suddenly during a race, and the post-mortem findings show the presence of 3-vessel coronary artery disease and evidence of a previous myocardial infarction. So in this age group, pre-participation screening based on 12-lead ECG appears to be not accurate test for screening coronary artery disease. And we have to find an alternative kind of screening. So in this age group, probably the best approach is that screening should be targeted to the assessment of coronary risk factors, because coronary artery disease is the most common cause of sudden cardiac death, and to demonstrate by functional test myocardial ischemia, or to evidence by imaging testing, including CT coronary angiography, the presence of coronary artery disease. So in conclusions, cardiac screening needs to be adapted to the age of the athlete to account for age-specific cardiovascular disease. Pre-participation in screening appears effective in preventing sudden cardiac death in young athletes, competitive athletes, less than 35 years of age, by identification of ECG detectable inheritable cardiomyopathies and channelopathies. Enhanced screening protocol, including limited exercise testing with ECG monitoring, offers the potential to detect adrenergic-dependent ventricular arrhythmias and the underlying non-ischemic left ventricular scar that is an emerging cause of sports-related sudden cardiac death. Serial ECG screening on the annual basis over childhood and adolescence increases the screening sensitivity for acquired or genetic heart muscle disease with a late onset phenotype. Finally, in middle-aged senior athletes, the most common cause of sudden cardiac death is coronary artery disease, and screening should be targeted to coronary risk factors and detect signs of coronary obstruction and or myocardial ischemia. Thank you for your attention.